So now we will consolidate everything we've learnt so far by looking at some questions, and these are typical and reflective of those which may appear in the MRCP Part 1 exam and possibly in Part 2 as well.
So question 1. Which of these features is not usually seen on X-ray imaging of the knee in a person with osteoarthritis? So A, joint space narrowing, B, subchondral sclerosis, C, calcified cartilage, D, osteocyst formation, and E, bone cyst. So as you guys remember, we mentioned 4 features that are very classically associated with X-ray findings on osteoarthritis, and quite simply, calcification of the cartilage was not part of them. Whereas A, B, D, and E are all quite classic features. These are really important to put into memory, reason being that the other inflammatory arthritis, they all have other features on X-ray, and that's why it makes it quite easy for test makers to question you on this. Question 2, which of these is not considered a risk factor for developing osteoarthritis? A, obesity, B, rheumatoid factor positivity, C, smoking, D, high impact occupation such as a basketball player, or E, age 80 years and above. So if you think about your risk factors that we talked earlier, we talked about obesity having a role in it because it increases your load. The smoking has a role in it, like pretty much anything else in medicine, and high impact occupation, and also increasing age. Increasing age is probably the most common risk factor for osteoarthritis. So as you can see, rheumatoid factor positivity is not going to have anything to do with developing osteoarthritis. And final question, which is which of these is the most common site for primary osteoarthritis? So we've got A, metacarpopharyngeal joint, B, wrist, C, ankle, D, knee, and E, elbow. And if you remember me talking to you about the fact that this is going to be most commonly on the weight-bearing joints, you will be able to correctly identify that this is going to be option D, and that's your knee.
So the first question, a 35-year-old lady with rheumatoid arthritis presents to her GP with recurrent urinary tract infections. She is prescribed a short course of trimethoprim. 2 weeks later, she presents to hospital with a white blood cell count of 1.5 times 10 to the 9 per litre, a hemoglobin of 65, and platelets of 100. Which drug has she been taking for rheumatoid arthritis? So you may already have some ideas, but let's look at the answer. So the choices here are sulfasalazine, hydroxychloroquine, abatacept, methotrexate, and prednisolone. So this particular interaction is one that's really worth knowing for the MRCP exams, as it can commonly come up as a multiple choice question, but also in clinical practice, as this is quite a common scenario, particularly if you are working in general medicine or rheumatology. The correct answer here is methotrexate, and this is because of the increased risk of bone marrow suppression when used with trimethoprim, so they should not be used together. Going on to the second question, which of the following drugs works by blocking CD20? So this is something we did cover in a previous slide, and the answer here is rituximab. And the final question, which of the following statements is true? So these are the choices. Rheumatoid factor is more specific for rheumatoid arthritis than anti-CCP. Rheumatoid factor is IgM against IgG. Anti-CCP is usually positive in cryoglobulinemia. Anti-CCP is positive in 90% of patients with rheumatoid arthritis. And osteophytes are commonly seen on X-rays in people with rheumatoid arthritis. So if we look at each statement in turn, as we discussed, rheumatoid factor is not more specific for rheumatoid arthritis than anti-CCP. Anti-CCP is the more specific antibody. In this case, answer B is the correct answer. So rheumatoid factor is IgM against IgG. Just to look at the other answers as well, which are incorrect. It is rheumatoid factor that's usually positive in cryoglobulinemia. And anti-CCP antibody is positive in approximately 70% of patients with rheumatoid arthritis. And osteophytes are an X-ray feature in people with osteoarthritis, not rheumatoid arthritis. So there we have the correct answer, which is option B.
Now let's do some questions. So question 1 is a 40-year-old obese gentleman present to his GP with an acutely swollen left ankle. He has a background of hypertension, high cholesterol, and CKD stage 2. Investigation revealed a low serum uric acid level with a CRP of 45. His white cell count is normal. His GP refers him onwards to the local hospital for further investigation and joint aspiration. What does the synovial analysis show? So remember that this is relatively a young gentleman who has presented with an acute hot joint to his primary care. He has some risk factors, including hypertension and high cholesterol and CKD stage 2. Options you have is A, positively birefringent needle-shaped crystals, B, positively birefringent rhomboid crystals, C, negatively birefringent needle-shaped crystals, D, negatively birefringent rhomboid crystals, and E, hydroxyapatite crystals. So if you think about it, remember what the scenario was, what sort of phenotype was getting described in terms of your patient cohort, and as a result of that you can think that the most likely diagnosis would be gout in this gentleman, and if you recall from my slide from the beginning, basically the diagnostic finding on a joint aspirate would be your option C, which is negatively birefringent needle-shaped crystals. Next question is, which of the following drugs is not associated with an increased risk of gout? So you remember from the mnemonic that I gave you, we talked about a few drugs that are very frequently associated with an increased risk of gout and are absolutely exam favorites. The options you've got in here are ethambutol, B, pyrazinamide, C, aspirin, D, isoniazid, or E, cyclosporine. And if you remember correctly, we know that isoniazid was not part of our mnemonic. Question 3 is, a 45-year-old gentleman presented to the emergency department with a 2-day history of an exquisitely tender, red and swollen left great toe. He has a background of brittle asthma. Blood tests reveal he has an acute kidney injury with an eGFR of 10. He has raised CRP and ESR. His serum uric acid is 500. What is the most appropriate choice of treatment for management of acute gout symptoms? So this is actually quite a common scenario, especially to primary care, and this is giving you the diagnosis already. It's telling you that this is going to be gout. The gentleman has got quite a few risk factors for it. So let's talk about our options. A, allopurinol, B, febuxostat, C, colchicine, D, ibuprofen, E, short course of oral prednisolone. So remember that you're trying to manage this gentleman's gout acutely, if you recall, we really talked about really three important drugs for acute management of gout, which were colchicine, NSAIDs, and steroids. So you already know that option A and B are not going to be correct, because those are the drugs that we use for chronic management. Amongst options C, D, or E, you recall that I mentioned that obviously thinking about patients with comorbidity, in particular patients with renal function, would be of particular importance. And this gentleman has got an eGFR of 10, and therefore he wouldn't be eligible for either colchicine or ibuprofen as an NSAID. And really the option that's left for you would be a short course of oral prednisolone to manage his acute hot joint, and then he will need to go on one of the options that we previously discussed as a long-term urate lowering therapy.
So let's try some questions now. So which of these conditions may predispose to calcium pyrophosphate deposition disease? So if we think back to that long list of possible metabolic underlying abnormalities and other conditions that was towards the beginning of this slide set, our options are Liddle's syndrome, hypoparathyroidism, hyperthyroidism, Bartter syndrome, and rheumatoid arthritis. So the most correct answer in this case is Bartter syndrome. So now coming to the second question, an 80-year-old gentleman presents to A&E with a 3-day history of an acutely swollen right knee. It is warm, red, and tender to touch with a large effusion. So this is by no means an unusual scenario actually in acute medicine. The joint is aspirated as per good clinical practice, and the treating doctor concludes a diagnosis of pseudogout based on the joint aspiration as well as an X-ray of the knee, which shows chondrocalcinosis. So, what does the synovial fluid analysis show under polarized light microscopy? So our options are positively birefringent needle-shaped crystals, positively birefringent rhomboid crystals, negatively birefringent needle-shaped crystals, negatively birefringent rhomboid crystals, or hydroxyapatite crystals. So those of you who've watched the previous episode will recognise this set of answers, because one of these is descriptive of gout, another is descriptive of pseudogout, which is what we want in this case, and the others are not very relevant in this particular question. The correct answer in this case is positively birefringent rhomboid crystals. And the final question, which of these joints is not usually affected by calcium pyrophosphate deposition disease? A, the first MTP joint, B, knee, C, the wrist, D, the elbow, or E, the shoulder. So the joint that's least likely to be affected is the great toe or the first metatarsophalangeal joint, which in comparison is usually affected by gout. So now let's try some questions based on what we've learnt. The first question talks about a 40-year-old gentleman who presents with a 6-month history of lower back pain with early morning stiffness lasting for 2 hours. He has no comorbidities or drug allergies, and his renal function is normal. He has a family history of psoriasis in his father and inflammatory bowel disease and arthritis in his grandfather. He is a smoker and works as a civil servant. Examination reveals marked restriction of forward flexion. What is the most appropriate first-line management? So there's quite a lot to tease out from this vignette, and this is quite a classic vignette that you may get in MRCP Part 1 or Part 2. So coming to the first part of the question, we've got a 40-year-old gentleman, so he's under the age of 45, presenting with quite a long history of lower back pain combined with early morning stiffness, lasting for a significant period of time, so 2 hours in the morning. So already we can kind of gauge that we're suspecting axial spondyloarthritis in this gentleman. He has no comorbidities or drug allergies, and this is important to know in case we wish to start him on a non-steroidal anti-inflammatory drug, as well as any other drugs. And it's also helpful to know his renal function in that regard as well. Coming to his family history, you may remember we said that HLA-B27 can be associated with psoriasis, and we haven't talked about inflammatory bowel disease, but there are specific forms of arthritis called enteropathic arthritis, which can be associated with inflammatory bowel disease. So again, we can see a picture, a pattern emerging within the family history as well. The fact that he is a smoker is also important. We know that smoking does lead to worse outcomes in this condition. So part of his management may be to advise him to stop smoking. On his examination, we can see that he's got marked restriction of forward flexion, and it would be important to do a full musculoskeletal examination as well. So looking at the answers, based on everything that we've discussed, the correct answer here is to advise him to stop smoking, refer him to physiotherapy, as we saw in a previous slide, and commence a non-steroidal, so in this case ibuprofen, and it would be important to also start him on a proton pump inhibitor as well and check for any history of gastritis. The other answers are incorrect. If we just go through all of them, on section A, advises the patient to stop smoking, but goes immediately to starting secukinumab. And as far as we know, the patient hasn't actually tried any drugs yet, so we need to start him on some non-steroidals first, provided there are no contraindications. The same holds true for etanercept. Hydroxychloroquine is not classically used for axial spondyloarthritis. And again, answer E is incorrect because we would wish to start a non-steroidal first before considering an anti-TNF drug such as adalimumab. Coming to question 2, which of the following drugs is not licensed for the treatment of axial spondyloarthritis? So the correct answer here is rituximab. Golimumab is a TNF blocker, secukinumab is the IL-17A inhibitor, and etanercept and certolizumab are also anti-TNF drugs. Rituximab is a CD20 inhibitor and is not licensed for the use of axial spondyloarthritis. And finally, which of the following may present as an extraskeletal manifestation of AXPAR? So the options are mitral stenosis, lower lobe fibrosis, scleritis, aortic insufficiency, or eczema. The correct answer here is aortic insufficiency. You don't classically see mitral stenosis associated with AXPAR. In terms of lung fibrosis, it tends to affect the upper lobes rather than the lower lobes. In terms of eye involvement, it tends to be a uveitis or iritis and not scleritis. And in terms of skin involvement, we would not normally associate eczema with AXPAR, but we do see psoriasis and occasionally erythema nodosum as well.
Now let's do some questions. So question 1 is, which of the patterns of the joint involvement are not typical of psoriatic arthritis? A. Arthritis mutilans. B. DIP joint predominance. C. Symmetrical sacroiliitis. D. Polyarthritis, mimic of rheumatoid arthritis. E. Asymmetric oligoarthritis. If you remember, we discussed in the first few slides that asymmetric sacroiliitis is not really associated with psoriatic arthritis, whereas the options A, B, D, and E are quite typical of the disease. Question 2. Which of the following is a typical clinical feature seen on examination of the hands in a patient with psoriatic arthritis? A. Dactylitis. B. Boutonniere's deformity. C. Heberden's nodes. D. Jacquard's arthropathy. E. Z-Thumb deformity. So if you recall from our first few slides when we talked about signs and symptoms of psoriatic arthritis, you will recall that the correct answer in here is going to be dactylitis or sausage finger, as is frequently described in textbooks. Options B, C, D, and E are all findings of other rheumatological conditions and arthritis that have either already been covered in our previous episodes or will be covered in our future episodes to follow. Question 3. Which of the following drugs is not licensed for the treatment of psoriatic arthritis? A. Infliximab. B. Apremilast. C. Upadacitinib. D. Baricitinib. E. Secukinumab. As you can see, this is asking you about refractory management options for psoriatic arthritis. And if you remember correctly, option D, or baricitinib, is currently not licensed for refractory cases of psoriatic arthritis as a biologic agent.
So let's move on to some questions. Firstly, a 30-year-old man with a history of intravenous drug use presents to the medical take with a hot, swollen knee. On general inspection, he has a swollen, tender left knee with limited range of movement, both actively and passively. The IMT1 doctor performs a joint aspiration, the result of which shows a white cell count of 120,000. Which of the following statements is not correct? So I'll just give you a moment to look at that question before we go on to the answers. So we're looking for the answer which is not correct. The options are 2 grams IV flucloxacillin QDS is indicated with a stat dose after aspirating. Pseudomonas needs to be considered. Measurement of lactate is necessary. An INR of 4 is a contraindication to joint aspiration. An X-ray of the left knee should be performed. So in this case, the correct answer is an INR of 4 is a contraindication to joint aspiration. This is not true. A high INR is not a contraindication, particularly in an emergency, and the joint should be aspirated. In this particular case, the patient is an intravenous drug user, so there's quite a high chance that he may have contracted an infection, and therefore all of the other answers are correct. Here's the second question. So a 50-year-old lady with known rheumatoid arthritis on methotrexate comes in with spiking fevers and a hot, swollen erythematous right knee of 2 days duration. She has recently been in hospital with pneumonia. The joint is aspirated and shows gram-positive cocci in chains. Which organism is most likely to be the cause of her septic arthritis? So here we are told she's got septic arthritis and we are given the gram stain. The options are Staph aureus, E. coli, Strep pneumonia, Pseudomonas, Mycobacterium tuberculosis. And the correct answer here is Strep pneumonia, not just because of the gram stain, which tells us that they are gram-positive cocci in chains, which would be consistent with a diagnosis of Streptococcus, but also we know that she's recently been in hospital with pneumonia, and therefore this is a plausible explanation. To conclude this series of videos on inflammatory arthritis, we're just going to recap some of the concepts we've learnt in the past few videos in the next set of questions. So the first question is, which of these HLA subtypes is associated with rheumatoid arthritis? So your options are HLA-DR2, B27, DR3, DR4, or B51. So the correct answer to this is HLA-DR4. It's worth knowing what each of these HLA subtypes are associated with as part of particularly the MRCP Part 1, as they do tend to come up quite frequently, and it's worth committing to memory so that those questions can be done quite quickly in the exam. Question 2, which of the following is not a typical examination finding in someone with rheumatoid arthritis? So the options are Z deformity, swan neck deformity, ulnar deviation of the MCP joints, Heberden's nodes, or boutonniere deformity. So the correct answer here is Heberden's nodes, which you'll remember is a feature of osteoarthritis, along with Bouchard's nodes. It is worth remembering that you can have coexisting osteoarthritis and rheumatoid arthritis in the same patient. So that's just worth remembering when you're examining someone, for example, in PACES. Question 3. A 30-year-old lady with rheumatoid arthritis attends clinic. She is on 20 mg methotrexate weekly and 200 mg hydroxychloroquine once a day. She is noted to have multiple tender and swollen joints with a DAS28 score of 4.7, so a decision is made to increase her methotrexate dose to 25 mg weekly. Which of the following blood tests are most important to monitor closely? So here we have a combination of pairs of blood tests. So which of these pairs are most important for the monitoring of methotrexate? So the options are full blood count and liver function tests and bone profile and renal function and full blood count, or thyroid function. Now, when you're initially assessing someone with rheumatoid arthritis, you may actually do all of these tests. And indeed, throughout the monitoring of someone with rheumatoid arthritis, particularly someone on an immunosuppressive drug, you may also wish to continue monitoring most of these blood tests, but the ones that are most pertinent for methotrexate are full blood count and liver function tests. Question 4. Which of the following is inhibited by tocilizumab? So the answer here is interleukin-6. Just going through the others, CD20 is inhibited by rituximab. TNF-alpha is inhibited by several drugs, so examples include adalimumab or infliximab. IL-1 is inhibited by anakinra, and CTLA-4 is inhibited by abatacept. Question 5. Which of the following is not typically found on X-ray imaging of the sacroiliac joints of a person with axial spondyloarthritis? So here we have several different features, which may or may not be true. So blurred joint margins, subchondral erosions, osteophytes, sclerosis, and fusion. So the one that stands out here is osteophytes, as that is usually seen in someone with osteoarthritis and not an axial spondyloarthritis. Question 6. A 25-year-old male presents with a painful swollen knee, urethritis, and a pustular rash to the soles of his feet. Inflammatory markers are raised, and an infection screen, including STD screen, identifies the presence of chlamydia trachomatis. Which other clinical feature is he most likely to have? So this is a diagnosis of reactive arthritis, specifically Reiter's syndrome. And you may recognize the pustular rash to his feet as being keratoderma blenaragicum. So the options here are mouth ulcers, scleritis, onycholysis, conjunctivitis, or a vasculitic rash. And the correct answer is conjunctivitis as part of the triad of Reiter's syndrome, which is conjunctivitis, arthritis, and urethritis. Question 7. Which of the following features is not associated with psoriatic arthritis? HLA-B27, nail pitting, arthritis mutilans, ulnar deviation of the MCP joints, or dactylitis. So as we've seen in a previous question, ulnar deviation of the MCP joints is usually seen in patients with rheumatoid arthritis and not classically in psoriatic arthritis. All of the other answers may be associated or seen in someone with psoriatic arthritis. And finally, a 30-year-old gentleman with psoriatic arthritis has very active disease with significant lower back pain and stiffness. He has only been on methotrexate in the past. Which of the following is the next best treatment option, provided there are no other contraindications? So you may already have some ideas as to what he would require next, especially given his significant back pain symptoms. So the options are tocilizumab, adalimumab, rituximab, hydroxychloroquine, or sarilumab. So the only drug listed here that's licensed for psoriatic arthritis is adalimumab, which is a TNF-alpha inhibitor. None of the others are used for the treatment of psoriatic arthritis.
Thank you for listening to this episode of Bite-Sized MRCP. If you like what you've heard today, give us a thumbs up and hit the like and subscribe button below to make sure you don't miss our next episode. Let us know in the comments which topics you would like to hear in future. See you in our next episode.